Absolutely.
Okay. All the best.
Thank you.
In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Thanks, Kama. I think we need to get Jeffrey King to be muted. Thank you very much. And welcome, colleagues. Welcome to our, so let me just get my video on. Our weekly webinar hosted by Clinics Health Group. We've been hosting this webinar since 2020 when we went on the lockdown. And we haven't stopped ever since because we found these webinars quite useful, that we are able to connect with quite a number of our colleagues on this platform. And we're also grateful that we've got colleagues who are speakers and experts in their own right, who are able to give us their time and share their clinical expertise, academic knowledge, and also research components that they are working on to share with us. And tonight it's by no means a different matter, because we do have great speakers lined up for us today. Normally we've got one speaker, but we've got two, because this is a matter that affects the Pharmacy Council and also the person overseeing the pharmacy, the regulators, from the point of view of the Department of Health. I think the only missing link is the clinicians who are working in the HIV/AIDS field, but they are here in numbers. They are able to interact. We hope that we get feedback and interaction from colleagues who are logged in this evening. Please note that these webinars are also CPD accredited, and when you log in, we request that you submit, you give us your full details, name and surname, mobile number, email, and also your registration number, whether you're from the Pharmacy Council, from the Health Professions Council, the Nursing Council, or the Allied Health Professions Council. And yeah, you see, Dr. Pillay, that this is all the people that you are responsible for as a Department of Health. They are all put together in one platform. We only The only people that you may not be looking after is the nursing council, who are part of this meetings that we're having this every week. And so this evening, and also note that this webinars are streamed live on YouTube. So at any time when you want to go back and watch and listen on the presentation that have been made, you're at liberty to do so. I know that most of you also sometimes ask for the copies of the presentations. We'll check if Dr. Pillay and Mr. Kimemuna will be at liberty to share these presentations at the end of the webinars. We chose to discuss this matter because it's been a matter that has been in the forefront of the discussions. It reached the High Court in this country. And so we thought it's quite prudent that we bring together all the role players under one roof, so to speak, and have this discussion to understand and get an update on the Pharmacist-Initiated management of antiretroviral therapy. We've got two speakers, as I've indicated. We'll first begin with Dr. Anban Pillay, who is the from the Health Regulation and Compliance with the National Health Department, the National Department of Health. And Dr. Pillay is quite an experienced administrator and also a clinician, is a qualified pharmacist and has been with the Department of Health for some time. And we won't go into the CV that has been submitted there, but he also holds a PhD in clinical pharmacy. So it's quite a pleasure to welcome you, Dr. Anban Pillay, to share your thoughts on this important topic this evening with us. You'll first speak, and then after that, we'll also get Mr. Kimemuna, who's from the Pharmacy Council, but also in private practice, overseeing the pharmacists, to give us a talk also. So over to you, Dr. Pillay, and thank you very much for accepting our invitation at such a short notice. Thank you.
Thank you very much, Dr. Bila, and thank you for the invitation and for organizing this event. A very impressive turnout on a Thursday evening, over 200 people participating in the talk. It's great to talk to so many health professionals all at once. I think the technology post-COVID has given us opportunities to reach people in a way that we didn't imagine before. So I suppose those are one of the positives out of the COVID experience. So as you mentioned, Dr. Bila, we're going to talk about pharmacist-initiated and management of antiretroviral therapy. This has been an issue of some controversy. As you may know, the matter has served in court, I think, as Dr. Bila had indicated. I do believe that much of the policy and the proposals are misunderstood, and I'm hoping tonight that we would be able to shed some light around it, and there can be a better understanding of what actually is intended by the policy, and actually what the policy covers and what it doesn't permit as well, because I think that's important. So I do have some slides which I'm going to share with you. My slides cover particularly around issues of human resources, and which is one of the drivers relating to how we ended up with some of the policies that we have, and then a little bit around the epidemiology of HIV that has led us to this point. Thereafter, Ms. Jackie Mayman from the Pharmacy Council will go through the PMAT program in terms of what the program covers, what the training was, who trained them, and exactly what they will be doing and what they will not be doing. And I'm hoping that at the end of both of these presentations, you would have a better sense about exactly what PMAT is about. So let me just put up my slides. I'm hoping you can see these slides.
Yes, Doc, we can see. Thank you.
Great, thank you. So I think it's important to start off with the global health workforce that we currently have and some of the challenges around that. Globally, we know we have an estimated shortfall around 18 million healthcare workers, with primarily these shortages in low-resource countries. I think many of the health professionals on this platform tonight are fully aware of that most of the human resources lie in the developed nations, and a very smaller proportion in the low resource settings, yet the low resource settings have the greatest need. And this deficit obviously impacts on countries being able to deliver healthcare services and achieve universal health coverage, as all countries are striving towards that for their people. We need to also bear in mind, as we have the shortfall, we also have population growth, and with population growth, this is going to be combined with changing demographics and epidemiology, which will increase the need for more healthcare workers. So we're starting with a deficit, but we anticipate that the situation may well get worse. So there really is a need for us to do something different. So if we look at the global health workforce and we look at it by region, I'm hoping you can see my pointer. You can see within the African region, for example, and we have in black medical doctors, and in yellow the nursing and midwifery profession. And you can see that where you have fewer than 10 medical doctors per 10,000 population, or fewer than 10 nurses and midwives per 10,000 population, you have a much larger bar. And you can see that the largest bar resides in Africa, followed then by the CRO region, which is the Southeast Asian region. These regions have been classified according to the WHO member status. You notice that the shortest bar is in the European region. So relatively speaking, we are in a far more serious situation as a continent relative to Africa. Relative to Europe, sorry. And then if you divide, if you depict the same thing by low income, lower middle, upper middle, and high income, the picture is more stark, as you can see there. So I think the point to make is that there are huge differences in global workforce across the world. So this has led to a number of recommendations relating to how these problems are addressed. The first is that I wanted to share with you was the Human Resources for Health task team that was appointed by the Minister of Health, and they've come up with a report that makes a number of recommendations on how we resolve the current human resources challenges that we have in the country. And the first point they made was that they state, considering the global evidence on task shifting and the effectiveness of mid-level workers, South Africa needs to adopt a more progressive and active approach than is the case at present, because clearly the extent to which we're doing that is fairly limited. The second point is that there might be better alignment between health workforce and the NHI system by increasing training and posts for mid-level workers, as well as creating suitable career paths for these categories. A number of the mid-level workers don't have suitable career paths, and that's a problem in itself. And then thirdly, if the task shifted to mid-level workers are appropriate, and these mid-level workers are supervised adequately, they will be able to deliver high-quality care after shorter training and at lower salaries, and more likely to work in areas where professionals are scarce. So that was the recommendation from the Human Resources for Health task team that was appointed by the minister. The WHO as well, on the issue of task shifting, has said the following: countries in collaboration with relevant stakeholders should consider implementing and/or extending and strengthening a task shifting approach where access to HIV services and other health services is constrained by the health workforce shortages. Task shifting should be implemented alongside other efforts to increase the number of skilled healthcare workers. So clearly, while we're doing task shifting, we must increase the number of healthcare workers to fill the gap in the future that may arise. So I wanted to also share with you the huge disparities that exist within our country and between our country and other countries. So South Africa has on average a national average of 33 medical practitioners per 100,000 population. This comes from the task force figures as well. So basically, this is per 10,000 population, we have 3.3 medical practitioners or doctors, which is way below the WHO recommendation of around 10 medical practitioners per 10,000 population. In the case of pharmacy as well, the number is much lower, sitting at around 11. So you can see that all of the healthcare workers in the public sector are constrained. You also see huge disparities between provinces, from the Northern Cape, where you have 45, to the Limpopo province, where it's 25. So this picture is the same in almost all categories. When you talk about medical specialists, Limpopo comes out the worst, etc. So there are a number of indicators that clearly show the disparities in workforce, both between South Africa and other countries and within the country as well. Now, task shifting is not an entirely new concept in South Africa. We've had this for many, many years, actually. You may know that the nurse-initiated management of antiretroviral treatment, or MODNMAT as it was called, or is still called, is the backbone by which we have the largest HIV program in the world, initiated largely by primary care nurses who had to be obviously trained in initiation of ARVs, and many patients were initiated on treatment at our primary care facilities through the hard work of primary care nurses at that level. And today we can be proudly saying we have the largest number of patients on HIV treatment in the world. Similarly, we've had task shifting in the case of optometrists. They are able to manage minor conditions in their practices. EMS personnel also have access to emergency drugs, where they're able to administer that at the scene of an accident, etc. And dispensing doctors is another example of task shifting as well. There are many more, I mean, if we look, but the point I think I wanted to make was that task shifting is not entirely new to us. We obviously must implement it where we see there is a problem with access, and the number of health professionals that deal with it are a problem. I want to now move to the HIV epidemiology to give you a sense about what's the real problem in HIV, and so why did we introduce PMAT here? So I want to cover the issue relating to 95, 95, 95, and then ART coverage. And thereafter, I'll hand over to Ms. Mayman. So what is this 95, 95, 95 that everyone's talking about? Well, the intention here is to try to suppress the transmission of HIV to a minimal level. And the only way we can do that is to put as many people as possible on antiretrovirals that are HIV positive. So in order to do that, the global strategy is that 95% of people who are living with HIV know the HIV status. So that's the intention of the first 95. The second 95 is where we must have 95% of the people who know the HIV status, that is, they're being positive, going on to therapy. So if you know your HIV status, you should be on ARVs, and that's the second 95. The third 95 is that 95% of the people who are on ARVs shouldn't just be on ARVs, they need to be virally suppressed. So that's actually the outcome we're clearly looking for in order to suppress viral transmission from one person to another. So those are the targets of the objectives of the program. Who are the population groups that one considers for ARV treatment? Well, there's children, adolescent girls and boys, adult women and men, obviously the categories of gay men and other men who have sex with men, transgender people, sex workers, people who inject drugs, people living in prisons and other closed settings, and those who are on the move, such as migrants, refugees, etc. So there are a number of population groups that are particular target groups for consideration. So let me now come to the HIV picture in the country, and I'm hoping that you can see this more clearly, but I do have some of the text on the right-hand side that may direct you. So these figures are as of June 2023, so it's about just over a month old. At that point, South Africa is at 95, 78, 92. Which means that we've achieved the first 95 target, but we've only been able to place 78% of those people on treatment, and of those people that are on treatment, only 92% of them are virally suppressed in terms of our performance towards the 95 target. The data also is available from the private sector, where we have a total of about 380,000 patients that are on ART, and I think this largely is covered through medical schemes. A number of the schemes cover ARV treatment since it's a minimum PMB. Adult females and adult males, this number is about 235,000 and 141,000 respectively to get to that total. Results from each of the subpopulations do vary, with the adult females being about 96%, and then the second 95 is at 82, and the third at 93. Adult males picture slightly worse. Well, the first 95 is fine. The second 95 is sitting at 71 as opposed to 95, meaning that many more need to go on to treatment. And then the last one is at 93 in terms of viral suppression. Children as well, much worse picture. Those are less than 15 years. It's 82, 66, and 67. So there are gaps across this cascade in terms of all of the groups. So ART initiation and retention have all underperformed in terms of trying to keep people on therapy, because the one thing is to start therapy, and the second is to make sure that people stay on therapy. And as you all know as clinicians, that with a chronic condition such as HIV, many patients don't remain on treatment for a long time for a variety of reasons. And so as a health system, we need to make sure that we keep them on treatment. So South Africa must increase the number of clients on ART by at least 1.2 million. For adult female, that requires an increase of around 600,000 in the case, and an increase of about 614,000 in the case of adult males. So coming to ART coverage, the ART coverage pyramid, on the left-hand side, what you have is the people living with HIV, females and males. That's how the graph is divided. Blue being males and the green color being females. The lighter portion of the bar refers to the number of people living with HIV, and the darker portion, which is shorter than the lighter portion, refers to the number of people that are remaining on treatment. And you notice whether you're talking about males or females, that there is quite a significant disparity in the numbers that are remaining on treatment. So it's a big part of the problem in terms of getting people to remain on treatment. On the right-hand side is the same depiction from the previous graph, just presented a bit differently, looking at ART coverage both amongst females and males, and here it's just divided by age category. And what you can see is that ART coverage is poor in some groups. So for example, the 20 to 24 group for females, very low, as well as going down in terms of the teenage years. It improves as people get older. It's also a much smaller population. On the male side of things as well, you can see a similar trend and as people get older. So clearly the younger males and females are an important target group and are probably not coming in for treatment or are not remaining on treatment once they are initiated. So a fair bit of work for us to continue to do the catch-up. And if you look at this provincially across the country, splitting this by the first 95, that means the number of people that are HIV positive and they know it. Generally speaking, we're doing quite well. This is the bar on the top left. On the top right of your screen is the second 95, and that refers to people that are initiated on treatment. Overall, we're sitting at 78%. As a country, and there are disparities between the provinces. And what that implies is that we are quite far off the mark in getting people onto treatment, because that's the dotted line is the target there. Of the people that are on treatment, getting them virally suppressed, a better picture than that one, in that once people are on treatment and they remain on treatment, they're generally getting a viral suppression. It's much closer to 95 than we are here. And so clearly the drugs do work and cause viral suppression, which is what we are targeting it as an objective. So the third 95 looks much better than the second 95. Chair, will stop here, and if we would allow Ms. Mayman to then do her presentation following mine. Thanks.
Thank you very much, Dr. Pillay, and for that informative presentation. Just covers exactly how we are doing as a country in terms of achieving the 1990, and also showing the number of healthcare professionals and the shortages that we have, and making a case for which is what JK will talk about, a need for this PMAT program. So as I indicated that there are two of you going to be talking to us, and before I hand over to JK, there are colleagues who want to find out if you'll be able to share the slides. Anban, are you willing to? Oh, you cannot mute. Oh, Kamu, can you please make both speakers able to unmute themselves? JK says she can't unmute us.
Yeah, I couldn't unmute. Thanks. Yes, I'm happy to share the slides. That's fine.
Okay, no, thank you very much. Yeah, I think we thought too much waste of time. We're going to be inviting Ms. Jackie Mayman to be speaking to us. She's the CEO of the Independent Community Pharmacy Association, and also a member of the Pharmacy Council, and also a pharmacist. She's got a BPharm from Rhodes University, and she'll be taking us through her slides also, so that you have an understanding of this matter that has been in the public eye about pharmacist-initiated management of antiretroviral therapy in access program, as you can see the presentation topic there. Thanks, Ms. Mayman.
Thank you very much, Dr. Bia. I can't switch my video on, it won't let me, but I'm sure when we do the Q&A, you can let me switch it on and everybody can see me. All right. Thank you very much for the opportunity to speak to so many of our colleagues. I really do welcome the opportunity to be able to show exactly what PMAT is aiming to do. So if I move straight on, we look at pharmacy. So primary health care is part of our core business, which relates mainly to public health interventions. These includes things such as education, counseling, lifestyle advice for healthy living. Part of the ethos is to try and keep people well. We also do infection prevention through vaccination, family planning, healthy lifestyle changes, screening for HIV, TB, diabetes, hypertension, hypercholesterolemia, and promoting adherence. And you heard Dr. Anban Pillay just speaking about the importance of being adherent to treatment, and that's regardless of the therapy, as this improves patient outcomes and reduces hospitalization and mortality. And then lastly, referral of patients to appropriate health professionals, either in the public or private sector, as and when required. So how can pharmacy help support the 95-95-95 targets, which we've just seen from Dr. Pillay? So there are many patients that come into a pharmacy. Pharmacy has no stigma attached to it. A person coming into a pharmacy could be coming in to buy a shaving cream. It doesn't necessarily mean that they are coming in for family planning or HIV support. Many of them are seeking OTC medicines for mild symptoms, and they may be completely unaware that they are HIV positive. So there's been a big drive from a pharmacy perspective to encourage HIV testing in your Know Your Status campaigns. And I'm very glad to see that we've hit that first target in the 95 targets. Offering them the opportunity to take an HIV test helps identify these undiagnostic and otherwise undiagnosed asymptomatic people. This test is done quickly, minimizing waiting times and at a low cost. The tests these days are not expensive at all. And also there are many self-screening test kits which a person can purchase at the pharmacy and can actually test themselves at home or in a private environment. Pharmacies are very widely distributed. So we are all over the country. There are 3,500 community pharmacies, and there are many institutional pharmacies in the hospital settings. Community pharmacies certainly have extended trading hours, often open 7 days a week. We've got 24-hour pharmacies, and this increases access. There are a large pool of healthcare professionals, pharmacists and nurses, and the mid-level workers that Anban spoke about, established logistics and supply lines, and advanced information systems. If the patient is positive, the opportunity exists for the patient to immediately receive treatment if within the treatment protocol. And I'm going to take you through those. So firstly, I just want to talk about other services in pharmacy. So family planning, EPI, and COVID-19. So public-private partnerships, pharmacists have, through supplementary training and Section 22A15 permits, been improving access to things like family planning services. I, for instance, got my permit back in 1990 and have been offering family planning services to state patients since 1990. There's also the extended program of immunization, where state patients can come into a private pharmacy, get the vaccine for free, and then just charge a minimal fee is charged for the pharmacist to actually administer the vaccination. And of course, recently, pharmacies were responsible for nearly 70% of all COVID-19 vaccinations given in the private sector. That was over 7 million vaccinations to people across both public and private spaces. So the concept of responsible task shifting, as Anban also mentioned, is not a new one. The PMAT through private sector pharmacies. Firstly, let's look at other primary care services that pharmacists offer. And think of this with the concept that these are opportunities to offer people tests for HIV, for instance, emergency contraception. So according to IQVIA stats, currently through private pharmacies, we are selling 100,000 emergency contraceptions every month. So that's 200 people that are having unprotected sex. And this is a wonderful opportunity to ask if they know their status and get them tested. We also, through public-private partnerships, do family planning and sexual health consults. We do well baby clinics and EPI, minor ailments treatment. Men come in often to the pharmacy for libido enhancers, dispensing prescriptions. This can be acute and chronic conditions, screening for HIV, and the selling of HIV self-screening test kits for partners at home. Wellness screenings, I've already spoken about the wellness screenings, which can be for the non-communicable diseases. Vaccinations, that's flu, travel, COVID-19, EPI. And then, of course, there are the national campaigns such as World AIDS Day. And then lastly, people who inject drugs very often are coming into us for our needle exchange or purchases. And there's also a wonderful opportunity to find out about their HIV status. So what is appropriate task shifting? And here's a summary of PMAT. So PMAT addresses the fact that South Africa is yet to meet those 95 HIV commitments. The program, PMAT, leverages an as yet unaddressed opportunity in high-risk patients. So a lot of what this program is looking at is also keeping negative people negative through PrEP and PEP. So they would be accessing services within private pharmacies. And as I've already shown, there's an enormous opportunity to address those at risk. The program further leverages SA's extensive pharmacy network and an existing private GP and state clinic referral system. This program provides support to both pharmacists and GPs for active case finding and referral. It's a natural evolution of task shifting from specialist HIV care in the early 2000s to GPs, subsequently to nurses. And as we know, 80% of all ARVs are dispensed by MODNMAT nurses in this country, counselors, and now to pharmacists. It uses South Africa's most experienced HIV public and private sector specialists and generalists to design the program, carefully thought through, comprehensive, highly regulated, strictly controlled. Many of these doctors designed SA's successful HIV task shifting guidelines for primary care facilities, nurses, and counselors. There is oversight by doctors at every level and incorporates real-time monitoring and evaluation. Training and knowledge evaluation is a major part of the program too. So what was the PMAT proposal? It's an extension of access to HIV care through the introduction of sustainable, safe, and comprehensive HIV treatment and prevention services through private community pharmacies. It includes the development of policy briefs, adaptation of clinical guidance, and the provision of clinical advocacy to have PrEP, PEP, and ART safely prescribed from within private pharmacies. So 80% of ART prescribed and managed by nurses in the public sector who are resource constrained and overburdened. And we still need to add another almost 2 million people, or I think Anban, you said it's actually 1.2 million people. The training program and application for a Section 22A15 permit is aimed at expanding both the pharmacist and the private nurse's scope of practice to include this limited list of ARVs. So the course was designed together with the Southern African HIV Clinician Society. And as we know, they have extensive healthcare worker training experience, utilizing key opinion leaders. I don't need to tell you the value that SACS brings with guidelines, training, and the wealth of information that comes from their GP network and their specialist clinicians. The PMAT curriculum itself, you can see there, consists of 18 modules or 160 notional hours, a 15-day face-to-face theory course. And if we look at MODNMAT, which is much broader, including the treatment of TB and ART across all population groups, and I'll show you just now that PMAT is a lot more constrained. MODNMAT consists of 20 modules. It includes 14 sets of multiple choice questions. MODNMAT has 16. 24 case studies, of which we need to do 10. MODNMAT has 29. It covers 8 competency standards set by the Pharmacy Council, and then, of course, a portfolio of evidence with 10 GP supervised cases. So that's the requirement for the PMAT. So if we have a look at the actual PMAT guideline, eligibility for PMAT. So in HIV negative people, that would be PEP, so needle stick, HIV exposure, and sexual assault. PrEP, on request after a risk assessment. And then for HIV positive people, it would be first-line therapy initiation in people over 15 years of age. They would be tested for HIV. They would need to test positive, have a CD4 count above 200. And then the last one would be ART reinitiation in people over 15. So here it would be HIV positive with interrupted ART, retest to confirm status, HIV positive transferring from clinic with records, and HIV positive transferring from clinic with no records. So this is on the state patient side. If we're looking at screening, so what the pharmacist would do is they would need to screen for comorbidities, taking a patient history. They'd need to look at previous and current medicine therapy, test for HIV, confirm the HIV result, and this would be with third or fourth generation rapid antibody tests according to the NDOH guidelines. We would check age, CD4 count, women of childbearing age, pregnancy, and ask if they're planning to conceive, screening for STIs, TB symptoms. We would be asking about things like current headache, and then of course creatine clearance to look at renal function. I think what is important is to look at what can a pharmacist not treat. In other words, when these people come in, these would be referred to doctors. So anybody under 15 is referred. Anybody less than 35 kilos, referred. Pregnancy or planning to become pregnant, referred. A CD4 count under 200 cells per cubic millimeter, referred. And to note here, we are not going to be doing test and treat. We would test, and then these blood works would need to be sent off. So we're being far more cautious than currently happens in the state sector, for instance. If there is any impairment of renal function, refer. TB screening, if that comes out positive, refer. Hepatitis B positive, refer. Any symptoms of opportunistic infections, and you can see them there, any of those would result in a referral, as would chronic diarrhea, STI screening, if that is positive, comorbidities, we will not be treating people with comorbidities. And then, of course, medicine interactions and contraindications, those would require a referral. If we do initiate treatment in an otherwise completely well person and there is treatment failure, those would be referred. And of course, any discordant results would require referral. So the guidelines are very clear as to who we can treat. So if we now look at the antiretroviral therapy, we would initiate ART, and this would be limited to PrEP, PEP, and first-line ARVs with TPT, strictly according to the NDOH guidelines and an approved formulary. We would deal only with clinical stage 1. The ART only initiated once the CD4 count and renal function and actually hepatitis B status is established. Our formulary would be combinations of tenofovir, lamivudine, emtricitabine, and dolutegravir. Any contraindications, referral. Any suspected toxicities, refer. TLD introduction has been a major success for the Department of Health, and the data suggests that there is minimal resistance. So adherence is a key intervention and monitoring viral load. The PHC nurses and doctors remain the bedrock of HIV management, and PMAT serves purely to be complementary. The intention of PMAT is to reach untested population groups who do not visit doctors or clinics. It's to identify high-risk individuals and keep them negative, and HIV positive people. We saw the drop-off between the 95% that know that they are living with HIV to the second one, which is those on treatment. These are lost to care. And so the idea is that a lot of people are being tested in pharmacy and they are possibly being lost to care. So it's to try and bridge that gap, to refer where appropriate and ensure linkage to care, to treat uncomplicated cases in otherwise well individuals according to the latest Department of Health guidelines, and to try and relieve some of the burden on the state facilities. It includes support from HIV clinicians. A lot of the support we get is via the Vula app, and if we're not sure, we ask. Partnership with local GPs and state clinics for referral is absolutely key. The pharmacists will not be successful unless we have support from the doctors in our areas. And then, of course, contracts with the path labs. If I look at the, show you the global trends, it is a global phenomenon. Now, you would think that South Africa would be the leader here, as we've got the largest ARV program in the world. But the global trend is to expand access. And here are some of the things back from 2019. California makes HIV prevention drugs available without a prescription. New York Times, new law, pharmacists undergo special training to be able to provide HIV prevention medications without a doctor's prescription. I had a look at the General Pharmaceutical Council, a guidance for pharmacist prescribers on ARVs. And this is in England, Scotland, Wales, New Zealand, and Canada. So the trend is there. And as I was saying, I think here in South Africa, Dr. Pillay has already shown the gaps, and the whole idea of PMAT is to try and stop those gaps and to bring this scourge under control. Thank you very much.
Thank you very much, Jackie, for this presentation and outlining the role of the pharmacist and the council in terms of discussing this matter. There are quite a number of questions that have been posted as expected. And I must just also indicate that I think in the court case that you had, the challenge was brought in by the IPA Foundation. We didn't invite them specifically, but I did send the invitation to individuals that I know who are part of the IPA Foundation just to be part of this discussion of they are here. Maybe before we go to the questions, just to outline the process that was taken by the Pharmacy Council in engaging stakeholders. I think one of the questions that has been posted, and I looked at the Government Gazette that was published by the Pharmacy Council, I think that was in 2021, that you engaging in the broader stakeholders, but maybe just take us through the process. This may have been ventilated at the court case in any way.
Absolutely. So there was broad consultation. A lot of the work that Pharmacy Council did was together with the Department of Health and the Clinician Society. And I know that I was on a number of these types of webinars together with doctors. It was with the HIV GP network. It was with the specialist clinicians. We had a number of meetings with the specialists. For instance, Professor Francois Fenter, Dr. Nell, Prof. Meinkies. We sat in many fora where we sat with HIV clinicians and with the GP networks. And as I say, the first step we did was to contact the Clinicians Society and to propose this to them.
Sure. What is the current status of the court outcome in terms of the program itself now?
So at the moment, as you know, the court upheld that Pharmacy Council had done due diligence and that sorry, that's my dog in the background, that Pharmacy Council's processes were correct. So at this stage, what we would do is get hold of the Department of Health again and to start the process. So the Clinician Society had developed a training course, and in fact, about 900 pharmacists had been trained, but of course that was put on hold. So the qualification now needs to be approved by Pharmacy Council. And then I think all of those pharmacists, because it was about 3 years ago, will need to undergo further training. Once that training is done, then they would apply for the permits. And obviously, SAHPRA would be engaged to look at the list of medicines. Every permit that is given out to a pharmacist is facility-based, so it would be linked to the pharmacy. And then the pharmacists can only prescribe within the parameters of the permit, which includes a formulary. And as I've already shown you from the list of medicines, it's a very short list. It's basically PEP, PrEP, and then the TLD regimen, first line ARVs.
Okay, thank you very much. Yeah, I'll go to Dr. Pillay.
So there are no pharmacists with permits at this stage.
Oh, I see. That's yeah. I think back to you, Dr. Pillay, at the presentation, I think there are the first two questions cover staff shortages, the doctor shortages, the training of doctors. And they have been quoted as having said that there was a shortage of doctors and there was going to be a plan to train doctors. And 5 years later, we still have a shortage of doctors in the country. You've given us a clear picture of what's happening, maybe just an update in addition to what you know of what you actually presented. What are the plans to increase the number of training of the training of doctors?
Thanks for that question. I mean, as you know, the training of doctors is quite a lengthy process. In addition to the training itself, establishment of new institutions or additional institutions for training of medical practitioners takes a long time. There is work that's currently being done to establish a medical school in Limpopo to get that going. There's also work being done to establish a medical school in Port Elizabeth. So there's an intention to broaden the platform of medical schools across the country to increase our training. And that obviously will be limited by our capacity to fund those institutions. And then secondly, to be able to find the appropriate trainers, academics, that is, to be able to impart their knowledge, etc., to these undergraduates. So it's still, I mean, going to take a long while, but we need to start, and we have started, obviously within the financial constraints that we have available to us. Yeah.
I think you still allow me to, but it is this hope that there are more training facilities being considered.
Yes.
And yeah, Angelique wants to take up the fight of the GPs. I don't know if it's you or JK would deal with it, but she says that while pharmacists could vaccinate, GPs still at present at point 0 for COVID. I know that we are over COVID. I know that there's been one case of one of the variants that has been identified for COVID, but not happy that still GPs can't vaccinate for COVID.
I'm not sure if that's still the case. I know at the time there were requirements in order to obviously take on the vaccination program, but I don't think that's the case now. But obviously the demand for COVID vaccination has been very low now. I don't know if GPs would still be looking to do that. Maybe with the new variant that may be the case, but I can certainly check with my colleagues as to whether there's any problem with GPs doing it. Far as I know, there isn't. If they're obviously willing to work with us around the requirements that we must comply with to
Sure.
do that.
And Rabotile Petla wants to know how can a GP partner with government for the API and HIV testing treatment? What steps are to be followed, and what are the requirements?
So the program around the EPI program I can talk about, because we haven't started the HIV treatment program, the one that the PMAT program hasn't been rolled out as yet. In terms of the EPI program, we at this stage do that at provincial level. So each province would work with primary care providers, provide them with the necessary drugs. And there's obviously a system of referral of patients, record keeping, and supply of drugs that needs to happen at a provincial level. Not all provinces are doing it, but those that are, I know that it's going quite well. We've had this in the past. I mean, many years ago, this was also part of the program. There were some problems with the accountability, etc. But I think this time around, people have tried to fix those. So I'm positive that these programs can continue. So you could do this through your provincial Department of Health. Yeah. Okay. If you're in the province that's doing that. Yeah, not all the provinces, as I said.
Yeah, and when governor wants to know, take it back to you. How do we mix shaving creams with primary health care? I think they asked a question, Dr. Pillay, perhaps we should address norms and standards that all healthcare facilities can use. Maybe both of you want to chip in there. Jackie first.
So I think what I was trying to highlight there is that pharmacy really is an unstigmatized type environment. We don't mix shaving cream with primary health care, but you could be popping into the pharmacy for something that is not medically related. And this is where the comfort comes. A lot of men will come into a pharmacy for something very simple, and there is an opportunity there. Pharmacists are highly accessible healthcare professionals. They can walk in and they can engage with us. And that's why we feel that certainly one of the hard to reach population groups is young men. We saw from the stats from Dr. Pillay, and they are regularly coming into the pharmacy. And that was the opportunity. So yes, no, we're certainly not using shaving cream for primary health care, but it is a way of getting people into the pharmacy.
And then getting it there being unstigmatized, that you won't know who's coming for
Correct.
what purpose.
Correct.
What reason.
Correct.
Any ideas about more regulation from your side, Anban?
Regulation for, sorry, just a bit of a general question.
The pharma, because I think there are concerns that, you know, you're mixing everything, but there seems to be no regulation. Though somebody did say that the pharmacy council does inspect.
This entire program will be regulated. There will be norms and standards, there'll be requirements. In addition to the course, obviously, the environment in which this is being done, the record keeping, etc. All of that will be part of the program that we'll need to sign off on. The OHSC will be part of this as well, because they'll need to regulate it, etc. So this is, I remember we were just at the stage of engaging with it when the court case happened. So we'll need to go back and look at how we then relook at this program and how we will be regulating it, etc., before we start issuing licenses or anything like that. Yeah.
And in task shifting, I think both of you touched on task shifting. Now, Thokozile wants to find out, with the pharmacists employing or working with nurses, she's finding that pharmacists are not necessarily doing their job of EPI, the blood sample collection. Is there a short course that will upskill the older cohort of pharmacists in this regard?
Sorry, just repeat that. Yeah, sorry, repeat that question, Dr. Bia. I missed the last part.
Yeah, I appreciate the task shifting, but is this within their scope of practice and curriculum content and context? I find pharmacists contracting registered nurses, not necessarily them doing their job of EPI, but blood samples collections. Is there a short course that will upskill the older cohort of pharmacists? Maybe just they may be lacking the skill.
Absolutely. So you're quite correct. A pharmacist is not a phlebotomist. So if a pharmacist doesn't have a nurse in the pharmacy, then we would refer patients that require blood tests to a pathology lab. I can't remember the last time a doctor took bloods from me. We all get referred in the private sector to the path lab directly. But we do work, and about hundreds of pharmacies have nurses, very competent professional nurses in the pharmacy that can take blood samples. I know as well that we are busy with a clinical trial where we are actually looking at using rapid diagnostics, dry blood blot type screening. And those are then, the patient can actually take it themselves and they get sent into the lab. So technology is amazing. New things are being generated all the time, and there are many ways of getting patients tested.
Yeah, and the program, 180 hours training program, is that sufficient for this extensive training that is required for the pharmacist?
So remember, the pharmacists already know the medicines. Dealing with medicines, we are medicine experts. So a lot of the training that the MODNMAT nurses undergo is around the pharmacology. So we don't require the pharmacology. So the MODNMAT course is a 5-day course followed by a 6-month like internship, so to speak. And the PMAT course, remember, we don't treat TB at all. We will not be going any further than first-line ARVs. We are not treating children. So there is a big chunk that is taken out of the MODNMAT course versus the PMAT course. So in fact, we are getting more training in a sense than, for instance, the MODNMAT. And we know that that's been a highly successful program. What we are looking at is, obviously, all of it is under the supervision of clinicians. We're not doing this on our own. So yes, the course, and I have sat through the course, it is an extremely comprehensive course. And everything that we do is within our scope. What this does is it just gives us access to the medicines. That's what the supplementary training does.
Okay.
If I can also maybe come in there, Dr. Bila, this was an issue that concerned us, that, you know, is this training sufficient? And the minister was particularly interested as well in understanding the extent of the training and whether it confers competence. The feedback that we received, and remember the people who put the course together and did the training are from the Wits Medical School, UKZN, as well as UCT Medical Schools. And all three of them had written in to the minister indicating that they are confident that the training that they afford is very similar to what they would do for anyone else that they thought was competent. So they believe that the 180 hours is an appropriate level of training, and the pharmacists are competent in terms of doing so. Yeah.
Okay, thanks for that. Yeah, this one, I always have fun with this. There's Anban Pillay and Anban Pillay. Yeah, he wants to know, you know, I think that in terms of consultation, Jackie, that you see, I know we spoke about there was a broad consultation with all the stakeholders, but it says none of the regulatory bodies were consulted, like the HPCSA, the Nursing Council, the CMS, but also then later on, there's a comment that you spoke a lot about the HIV Society of South Africa, but that he then says that, you know, we tend to forget that the society seemed to have split in half, that 50% of them went away to form another association. I don't know if that is it was a factor in your consultation or not, but you comment from your side?
So whenever we're looking at expanding a scope of practice, it actually has nothing to do with the Council for Medical Schemes. So we would never have gone to the Council for Medical Schemes. This was a pharmacist-related program, and traditionally, we do not go to the HPCSA or to the SA Nursing Council, as they would not have come to SAPC when they were looking at dispensing doctors or at MODNMAT. It's just not how we do things. So what we did was we tried to address it properly. And the Clinician Society, the HIV Clinician Society, is probably the most prominent body in South Africa, together with the Department of Health. Remember, the Department of Health, though the bulk of people that are on ARVs are within the state sector. So through the Clinician Society, we did have a number of engagements, and it was pretty popular knowledge. And as I say, I know that I personally sat through a number of webinars where we were asked questions by doctors. And then, as I say, right in the beginning, the engagement we had was at university level. So it was at UCT, it was WITS, it was KZN. We addressed the professors there. Then, as I say, the Clinician Society. And then the last thing that the Pharmacy Council always does is to publish it in the government gazette. So we followed all the normal procedures, the same as we've done for family planning previously, the same we've done for vaccinating. There was nothing different this time around.
Sure.
If I can also come in here, Dr. Bila, I think the events relating to this particular matter, we would probably like to have done differently, had we appreciated the concerns relating to it. And I think the Pharmacy Council does as well. So we have a structure, a formal structure, which I'm sure you're familiar with too, the Forum of Statutory Health Councils. And so we did agree, even before this judgment came out, that any future policy that's coming through any of the key regulatory bodies, whether it's a Pharmacy Council, HPCSA, or Nursing Council, it will first be tabled at the forum, particularly where there's overlap between professions, with the view to try and resolve those before it actually proceeds any further in terms of public comment or the like. So I think Pharmacy Council also has a realization that it's not good to have this tension. It's not intended, and so we've signed off on that already. Yeah, thanks.
Now, I think this is good here. I think all the colleagues right here will be happy to hear that has been taken care of, and there was an omission from the side of the Pharmacy Council, but the broader stakeholder engagement meant also engaging the other colleagues in the regulatory bodies, even though the members or people who subscribe to those bodies were consulted, but regulation should have been a key factor in dealing with this matter. Now, in terms of we spoke about this, that the patients see pharmacists, and if PMAT gets off the ground, who would take responsibility for it? Or are the pharmacists covered by insurance? And do the patients have an idea that they are seeing someone that you explained that pharmacists understand medicine, but the training that they are being treated by someone with a limited hours of training in terms of treatment?
Absolutely.
2 questions, please.
So pharmacists do have professional indemnity. We absolutely have to have professional indemnity. And part of what we did from a Pharmacy Council perspective when we were looking at this was to go back to the insurers and to have a look at how that risk would change when we started prescribing ARVs. So pharmacists have been prescribing for decades for minor ailments. We prescribe Schedule 1s and 2s all the time. We also have access to other schedules, for instance, malaria prophylaxis, where a Schedule 4 medicine is descheduled to Schedule 2. So we already have professional indemnity, and part of our inspections is that we have that in place. The insurance companies have come back to us, and it would require higher insurance. From the perspective of the public, I think the public are well aware that they're dealing with a pharmacist, just the same as if the public goes to a nursing practitioner. They know that it is not a doctor. I think part of what we do as well, if we are seeing patients, is to explain to them if they do need to be referred. And just from some of the comments in the box there, it's not that our failures will be referred. It's that these hard to reach populations that are coming into the pharmacy is that we can identify them. And then if it does not fall within the scope of our permit, is to get them referred and to ensure that they do get to the doctors. So we really see this as an access program, and it will mean that the doctors are actually seeing more patients. That is the whole idea of this program, is not to take anything away from the doctors, but to rather to bring more in. The whole idea is to get to the undiagnosed and untreated population. Thanks, Doctor.
Yeah, when you mentioned undiagnosed now, your comment is that, are you now doing CD4 tests?
We diagnose with rapid diagnostics.
Is it? Okay, that's a question I think that someone wanted to know. Yeah. The question is from Rashid Adam. Noor. A GP cannot practice inside a pharmacy. Why now a pharmacist is allowed to do a GP work inside the pharmacist? Are you muted? Okay, Dr. Pillay, go ahead.
Yeah, I think that may relate particularly to the differences in the statutory bodies, because the Nursing Council and the Pharmacy Council and the Health Professions Council are independent bodies, as you know, Chair. And so they would make rules about the health professions that they are regulating. So it's, I suppose, a question that needs to be put to the relevant professional council that prohibits a particular. I think particularly now with the NHI proposal around group practice, that would need to be looked at by all the professional councils, because there's no reason why the professionals can't work together. It's actually a benefit to the patient if they did.
Yeah, I think this okay. Go ahead, Jake.
Sorry, Dr. Pillay, I couldn't unmute again, so apologies. Thanks for coming in, Dr. Pillay. No problem. So well, since probably the early 90s, pharmacists and nurses have been working together. So certainly from a pharmacy council perspective, we welcome being able to work with doctors. Unfortunately, up until now, the ethical rules from the HPCSA side prohibited doctors, or you have to get special permission. So we do have a number of doctors who have rooms within pharmacies, and we have a number of models. For instance, the Medicross model and Pharmacross, where you've got pharmacists, doctors, and nurses working together. I have seen the new proposed ethical rules from the HPCSA, and they are talking far more to multidisciplinary practices. And I think this is really important. You know, as we move towards universal health coverage, perhaps NHI, and we've got the contracting units of primary health care, you know, I think pharmacists, doctors, nurses, dentists, we all need to be able to work together and support each other. There's 60 million people in this country that are going to need help. And as we've been shown, there's a shortage of all healthcare professionals. So certainly from a pharmacy council perspective, from a pharmacy council perspective, there's nothing stopping doctors working with pharmacists.
Yeah, well, I think those ethical rules, I think there's been a coverage about that there's been a delay in dealing with those impugned ethical rules of the HPCSA. I see Siva Pragas Pillay has signed up. If you want to comment, you can unmute yourself, or Kamo allow him to unmute himself and make a comment.
Yeah, I just want to say I listened to this thing, and it looks like it's ending up to be a competition between professional competition between doctors associations and the pharmacy associations. And I think that is coming from the Department of Health not providing lead into this. If we have to accept in our country that we have got the largest, it's a large pandemic in sub-Saharan Africa, has got the largest HIV prevalence, and that by active treating and by getting people to be having undetected viral loads that can actually prevent spread of the illness, then we should be having a national program that is coordinated, collaborative, and in a method where we are tackling this pandemic in such a way that we should be able to defeat this illness and prevent further spread of illness at the present moment. Now, that requires us to have a registration system, procurement of drugs at a very cost-effective rate, flooding the drugs into the market, making the drugs accessible to the people, and in any method in which increases accessibility for those drugs to reach people in all areas, then that is what we should be doing. What we are looking at here is patchwork. And some of the things that were supposed to be done is not done. Now you talk about NHI and we talk about integrated practices. Yet the Department of Health has never come back with an integrated method of accrediting. We still have HPCSA separate, nursing council separate, pharmacy council, and each of these councils are competing with each other rather than looking at the healthcare of the patient and looking at how we can build integrated delivery systems that can make healthcare accessible to the people, such that when situations like this come, if you look that we have had the largest rollout of ARVs, but we have never been effectively managing this illness and controlling it, that is because there is a lack of coordination and a lack of process and a lack of a methodology to say, how do we tackle this national problem that we are facing in an integrated manner? And I think that's what should be looking at. Should not be looking at whether pharmacies are dispensing medicines or who gave them the right to, how did they get the right to. We should have a national plan that makes drugs, makes healthcare accessible.
No, thanks a lot, Siva. Dr. Pillay, Anban Pillay. Yeah. Maybe you seem to be fading at some point there. I'm not sure if it's my network or yours. But let Anban, if you could comment. You were in charge of at some stage of the NHI program, and I'd be correct if I say that what Siva Pillay is saying is part of what NHI is aiming to achieve.
Sorry, Dr. Pillay, my mic.
You're muted.
Can you hear me?
Yeah, just unmute yourself. You're still muted.
Hi, can you hear me, Dr.
Yeah,
Pillay?
I can hear you. Yeah.
No, I was saying I would certainly agree with that.
Yeah, I can hear you.
Yes. I would certainly agree with that. That
Yeah,
the
go ahead.
NHI, the NHI is intended to integrate those services as well as regulation between the various councils. Yeah,
we are losing you. I don't know if it's my side.
Dr. Pillay, I think it's your side. I can hear Dr. Pillay. Yeah, Dr. Pillay's dropped out. Anban, I can definitely hear you.
Okay. We'll just wait for Dr. Pillay.
So I got bombed out there. I don't know if you're able to talk.
Can you hear me now?
Yeah, I can hear you. It was on my side. Yes, go ahead.
Okay. Now, I was saying, yes, you're absolutely correct. The NHI is intended to integrate the coordination and regulation between the various professional councils with a view to have multidisciplinary practices deliver services to patients as opposed to what we have now. So I think that would go a long way in managing a patient who would, in the current environment, have to go to different professionals, and would you basically have a service under one roof as such.
Okay, thank you very much. I think in the process of getting logged out, I lost all the questions. I can't see any more questions. But in any case, we are almost towards the end of the webinar. I just want to comment on someone was saying that why can't we have these webinars at 7 p.m. We tried that, but 6 p.m. works well for us, and we do have quite a number of people logging in at 6 p.m. As you can see the numbers, and we've been able to get a steady number of more than 200 participants and 300 at some stage. I think there's a question: how are pharmacist assistants going to be upskilled to run this program, especially those in the rural areas?
So, Dr. Pillay, pharmacist assistants are mid-level workers, as doctors have got mid-level workers as well. And the idea is that they take over some of the mechanisms of dispensing. So, for instance, in a dispensary, the pharmacist would assess a prescription, The picking and putting labels on is done by the pharmacist assistants, and then the pharmacist would complete phase 3 of the dispensing, which is handing out and counseling. The pharmacist assistants will not be part of PMAT. It is not within their scope of practice. So really the idea is that they would take over more of the nuts and bolts of dispensing to free up the pharmacist to develop more of their clinical skills. Talking about having pharmacist assistants in the rural area, they can only work under the direct supervision of a pharmacist. So you are never going to have a pharmacist assistant without a pharmacist, and it would be the pharmacist or the pharmacy nurse that would be doing the PMAT or MODNMAT.
Okay. Are there any program to support the dedicated PhD doctors to bridge this gap in the communities they serve?
Sorry, just repeat that. You were breaking up.
There's a focus on the pharmacists, but is there a program, maybe Anban can respond to this one, to bridge this gap by supporting the doctors who are in the dedicated PhD programs?
The doctors in the dedicated PhD programs relating to HIV treatment, you mean, Dr. Pillay? Hello?
Yeah.
Did you hear me?
I think perhaps I think this could refer to, because you said there's still NIMET, because the doctors can work with the nurses in those PhD programs. So the focus would be to train the nurses.
Yes, and doctors obviously
because the question was about what about the doctors in the rural areas?
Well, I mean, doctors don't need any, upskilling or anything like that. They would obviously be managing these patients on their own. They don't need any training or any of that.
Definitely, yeah. Okay, I don't think we'll be able to continue. There are still a number of questions that I missed because when I was bombed out, I lost all the questions. But it's just left for me to thank you both, Dr. Pillay and Mr. Kimemen, for taking your time. I must say, been at short notice to be part of this webinar this evening and give us such information about the PMAT program and what the future holds. And we, as Dr. Pillay was saying, we should not be a to and fro between the doctors and the pharmacists and nurses, but we should be seen to be working together. There's a problem out there, and let us look at the best way of addressing it. And as Dr. Pillay said, the broader consultation could have been done better. In that if the regulatory bodies there's a forum for such discussions, that if there's any project or program that would affect the other colleagues in the different bodies, that there should be some form of engagement. So I just want to thank you very much for this engagement discussion, and to thank all the colleagues who joined us once more this evening, and for your support. That we've got quite a steady number of, if I may say, followers on this program, and it's because of you that we are able to keep these webinars going. Next week we are continuing still on HIV/AIDS program. We're getting a speaker. I'll be talking about management of HIV/AIDS and TB in particular. And so just want to thank you, and please do log in again and join us next Thursday as we continue with these webinars. Also to thank the marketing team from Phoenix Health Group, working together with the team that we putting together these programs and getting speakers and confirmation, and also making sure that all the colleagues who log in get their CPD points. I just want to say thank you very much to all of you. Until we meet again next week, have a good night. Thank you very much.
Thank you, Dr. Pillay. Thank you. Bye-bye.
Bye-bye.
Good night.
Night.
Thank you, Dr. Pillay. Good night.
Night, okay.
Thank you, Anban.
Good night.
Night.
Good night, colleagues.
Good night, colleagues.
Good night.
Night.
Bye.
Bye-bye.